Hello, my name is Jason Theobald. I'm an Associate Director of Portfolio Strategy and Development for Allergan Aesthetics, an AbbVie company. Allergan Aesthetics develops, manufactures, and markets a portfolio of aesthetic leading brands and products. That portfolio includes facial injectables, plastics, body contouring, regenerative medicine, skincare, and more. Allergan Aesthetics is proud to sponsor this evening's webinar series, one of four, Best in Breast. On behalf of Allergan Aesthetics and AbbVie Worldwide, congratulations PSRC for yet another successful meeting. Thank you.
This paper is entitled Breast Implant Associated Anaplastic Large Cell Lymphoma Incidence, Determining an Accurate Risk by Jonas Nelson and co-authors from Memorial Sloan Kettering and the Brigham.
Well, thank you for the opportunity to present. Is everybody seeing the screen?
Yes.
Perfect. So as everyone knows, at this point in time, ALCL is a significant public health concern, certainly for our field and beyond. But I think a better understanding of what is the current risk and incidence of BIA-ALCL is warranted. And to this point in time, an appropriate risk assessment from the epidemiological perspective has been elusive. Risk has increased over the past several decades from about 1 in a million to a number of 1 in 3,000. But we felt at MSK that this may in fact be higher than this, and so sought to better potentially understand this. Some of the difficulties with determining a risk come in determining an accurate numerator and denominator. In terms of the numerator, everyone has heard of the profile registry, which is a great resource in terms of reporting cases of ALCL. And the FDA website certainly keeps an updated number of cases of ALCL. The denominator, however, is equally challenging, as to date, many of the risk assessments have utilized sales data, which can actually inflate the denominator. So there have been a number of limitations. Additionally, unilateral and bilateral patients to this point in time have been assessed equally, and that begs the question of, is this an all or none phenomenon? So the purpose of our study was to really determine both the incidence and incidence rate of ALCL by year of implant exposure on both a per patient and a per implant basis, and then to analyze trends in implant usage over time to better understand the future impact of device use and characterize the burden of risk. So we performed a retrospective study of a prospectively maintained data set, examining patients from 1991 to 2017. We assessed demographics, with a very detailed focus on surgical data, including dates of surgery, implant type, both with regards to the surface type, but also manufacturer and laterality of the device as well. We also assessed the record for confirmed diagnoses of ALCL. We then performed a Kaplan-Meier time to event analysis on both a per patient and per implant basis regarding exposure to textured implant devices. And as you all know, Kaplan-Meier event analyses take into account censoring or patients being lost to follow-up. We did this on the exposure time being calculated from the date of surgery to last follow-up with an MSK provider, which we used claimed as the follow-up exposure, and then performed a separate sensitivity analysis, assuming an event-free exposure to device from the date of implantation to either a date of death or the end of the study period. Overall, just under 10,000 patients were included in the study, 6,000 of which had approximately 10,000 textured implants. The total implant years of textured exposure were just over 67,000. Examining the cohort, we can see that patients were predominantly white, and about 20% had a history of radiation therapy. 62% had bilateral reconstructions, and if we look at textured devices, the median implant follow-up time was 6.5 years, and for the vital status exposure, it was 9.4 years. 11 patients were diagnosed with ALCL during the study period. All of these patients had exposure to a textured device, The median time to diagnosis was 10.3 years. And the most common presenting symptom was seroma. Examining the incidence, we found that the overall incidence was 1 in 559 patients, or a per implant of 1 in 871. The patient year incidence rate was 1 in 4,020 years. Examining the time to event analysis, one can see that from 0 to 6 years, the incidence was essentially 0. But after that 6-year time point, there was a significant increase. If we look at this a bit more closely, you can see that at the median time to diagnosis of about that 10 to 12-year mark, the incidence was 4.35 per 1,000 patients. The vital status analysis demonstrated a similar trend. As we look at implant usage over time, with the gray line being the total implants, the orange line being textured implants, we can see that we reached a peak of textured implant usage around the year 2010 or 2011. And this has significantly decreased through 2017, and now we very rarely utilize textured devices. If we look at this a bit more closely, and this is again an annual textured patient volume compared to exposure years, the volume is in the blue line. The red line indicates a 10-year exposure number from 2020. So the area under the curve, which is in the shaded red, represents about 70% of patients who have passed that 10-year time point. But importantly, 30% of patients in our cohort have yet to approach that 10-year. So in conclusion, our findings suggest that the incidence and incidence rate of ALCL may be much higher than previous estimates suggest, with about a 1 in 559 lifetime risk with a 10-year exposure average. And given the number of patients with textured devices, this prevalence of ALCL will likely increase over the coming years. Just as a reference, if you're interested in learning more about these studies, we have published both the single surgeon experience, which was led by Dr. Cordero, as well as the institutional experience. Just wanted to thank all of our co-authors. Thank you for listening.
Very good. Well, thank you, Jonas. I enjoyed the presentation. If we can move forward to our second, just to update everyone, we're going to proceed with a few abstracts first, and then have a small session for questions, so we can hold off on any feedback right now. However, we invite viewers to populate the chat room if there are particular questions. That way we can ask them during the discussion section. Very good. Well, our next presentation will be by Ashraf Patel from SUNY Upstate in a collaboration with Stanford University, entitled Single Unit Technique for the Use of Acellular Dermal Matrix in Immediate Two-Stage Breast Reconstruction.
Hi, everyone. My name is Ashraf Patel, and I am a fourth-year medical student at SUNY Upstate Medical University. Today, I'll be discussing my research that was done at Stanford that proposes a novel technique for utilizing ADM in two-stage breast reconstruction. We'd like to thank the scientific committee for allowing us to present our work today. These are our disclosures. So in subpectoral breast reconstruction, ADM is commonly used as a sling to better support the tissue expander. The pec major can provide upper pole coverage while the sling supports the lower portion of the tissue expander. Manipulating the ADM to create the sling in the breast pocket can be unwieldy. So at best, this could just be a minor nuisance, but it can also contribute to increased operative time, wrinkling, or even discrepancies in symmetry between the two breast reconstructions. Therefore, we present a novel technique that involves preparation of the ADM and the tissue expander on the back table as a single unit. So our project aimed to describe our technique as well as evaluate its efficacy through assessing postoperative complication rates. So this is a description of our technique. So basically, perforations are made through the ADM, and then the tissue expander tabs are passed through this and secured with sutures. This allows us to then move the ADM and the expander as a single unit into the breast pocket and then position it at the level of the inframammary fold. The image here on the left depicts this expander ADM complex being assembled on the back table. And then this is the image on the right, which depicts what the final product looks like before it goes into the breast pocket. So this video depicts our technique. Here, we're seeing the ADM is placed above the tissue expander and we're viewing the expander from a posterior view. You can see the perforations in the ADM, and then the tissue expander tabs are passed through this and then sutured and secured, and this creates the single unit of the ADM and the tissue expander. So our study was a retrospective chart review over about a 4-year time period. All of our patients were operated on by a single surgeon, the senior author, and they all involved ex vivo preparation of the ADM and the tissue expander complex on the back table. We collected demographics, comorbidities, oncologic history, and perioperative data for all of our patients, and then we reviewed our charts for complications between stage 1 and stage 2 of breast reconstruction. So this is what our data looks like. We had a total of 62 patients and 108 breasts included in our series. In this table, you can see the patients are split into whether they experienced one or more complication. Overall, the demographics were similar between patients when separated into these two groups of whether they had a complication, with the exception of BMI and obesity, which was found to be more prevalent in patients who experienced complications, and that's expected. We had a total of 108 breasts reconstructed utilizing this technique. Nipple-sparing mastectomies were overall the most common among our patients, and almost all of the expanders were filled intraoperatively with saline. The patients didn't receive, a majority of the patients did not receive either pre or post-mastectomy radiation therapy. And when comparing differences in breasts that had or had not experienced a complication, we find that these perioperative endpoints are pretty similar overall. When looking at complications, specifically following stage 1 of breast reconstruction, which is placement of the expander with the ADM, our most common complication was mastectomy skin necrosis at about 9.3%, and that was followed by infection at 8.3%. This is in line with previously reported complications in breast reconstruction at both our institution as well as previously reported numbers in the literature. So we're able to see that our technique doesn't necessarily increase complication rates. 10.2% of our patients required tissue expander replacement, and 3 patients, or 5 breasts, underwent expander explantation. Of these patients, of these 3 patients, only one of them actually experienced a complication, which is bilateral skin flap necrosis, and opted for expander removal and did not want to undergo reconstruction. And then the other 2 patients who had their expanders removed didn't experience any complication. They just wanted to have their expander removed and did not want to pursue any further reconstruction just for personal reasons. So from our experience, we find that our technique proposes a simpler method for utilizing ADM in this subpectoral reconstruction as a single unit. We find that we get excellent outcomes with no increase in overall complication rates as compared to previously reported rates. And we believe that by utilizing this technique, there can be increased consistency in expander placement and stability and expansion, as well as preventing window shading of the pectoralis. Thank you for your attention.
Excellent. Thanks, Dr. Patel. Okay, our next presentation is going to be entitled Evaluating 90-Day Readmission Rates and Clinical Outcomes in Breast Reconstruction, Utilizing a National Database by Dr. Marquez from Stony Brook.
Hello, can everybody hear me?
Yes.
Hi, good evening. Thank you for the opportunity to present our work. I'm going to disclose. Breast reconstruction is one of the most common procedures performed in plastic surgery. Last year, the ASPS determined that about 100,000 cases of breast reconstructions were performed. 72,000 of these cases were tissue expander or implant-based, while 19,000 were autologous reconstructions. Many studies have evaluated the risk of complications between various methods of breast reconstruction. Some studies have done so utilizing a local database. However, oftentimes they require larger sample sizes. Recently, many papers have incorporated large national databases in order to further shed light on this topic, but they're often limited data, only capturing postoperative complications up to 30 days. For this reason, there's concern that such studies may underestimate the true risk of complications after breast reconstruction. For this reason, the purpose of our study is to evaluate differences in outcomes between various types of breast reconstruction, including tissue expander and autologous breast reconstruction up to 90 days postoperatively. A Cerner Health Facts database was queried using breast reconstruction ICD-9 codes between 2000 and 2017. Patients were stratified based on procedure type. Data on surgical complications, readmissions were analyzed up to 90 days. Techniques included tissue expander only reconstruction, concurrent tissue expander with isthmus dorsi, and as well as autologous reconstruction only. There were 9,800 patients included in our analysis. 7,400 were tissue expander based, and 2,300 were autologous reconstructions. They were further stratified into 3 major groups. Group 1 was tissue expander only. Group 2, tissue expander with isthmus dorsi, and Group 3 included the autologous reconstructions only. When comparing groups 3 to groups 1 and 2 for readmission rates within 30 days, it was found that group 3, or the autologous reconstruction group, were more likely to have readmission rates within 30 days compared to patients who undergone tissue expander reconstruction only or tissue expander with a isthmus dorsi. There were no differences in readmission rates between 31 to 90 days postoperatively between groups. When looking at groups 3, the autologous reconstruction group only, comparing it to the other groups, group 3 compared to group 1, tissue expander only, group 3 was most likely to experience hematoma, bacterial infections, cardiac dysrhythmias, medical complications, fat necrosis, overall wound complications, and any complication within 90 days postoperatively compared to those who underwent tissue expander reconstruction only. When comparing patients with autologous reconstruction to those with tissue expander with isthmus dorsi, or group 2, group 3 were more likely to experience hematoma or hemorrhage, fat necrosis, overall wound complications, and any complication within 90 days. Lastly, we performed a sub-analysis of our autologous groups comparing free flaps to pedicle tram flaps. And it was found that patients who underwent free flaps were more likely to experience hematoma within 90 days. In conclusion, tissue expander only and tissue expander with isthmus dorsi reconstruction had lower incidence of early complications compared to other types of reconstruction methods. Autologous flaps are at a higher risk for readmission and significant complications up to 90 days compared to tissue expander only and tissue expander with isthmus dorsi. Within the autologous reconstruction groups, free flaps were more likely to develop hematomas compared to pedicle flap. And there were no difference in outcomes or readmissions between tissue expander only and tissue expander with isthmus dorsi breast reconstruction. We do recognize some limitations with our study. Is retrospective nature is one of the limitations. Another limitation is coding error that can be associated with retrospective databases. Investigators are also restricted to only data that is collected and recorded and accessible within the database, which is outside the investigator's control. Also, the database does not provide specific details about technique, such as prepectoral versus submuscular tissue expander reconstruction. And lastly, any patient who may have sought postoperative care outside of a Cerner institution would have been considered missed data and not included in the analysis. Thank you for your time. Looking forward to any questions. Thank you.
Okay, very good. Thank you. Our next presentation will be coming from USC, and it'll be titled Pre-Pectoral Breast Reconstruction Using Meshed Acellular Dermal Matrix, a Resource-Conscious Approach, with Emma Vartanian.
Hi, good evening. Thank you all for the opportunity to present our work. Their disclosures. Prepectoral reconstruction provides a safe alternative to submuscular reconstruction that offers several advantages, including avoiding animation deformity and reducing postoperative pain and recovery time. However, most approaches require complete acellular dermal matrix, or ADM, coverage of the implant, resulting in increased cost and utilization of a limited resource. We present a method for prepectoral breast reconstruction using a skin graft meshing technique to increase the surface area of usable ADM while still maintaining its structural integrity. We performed a retrospective review of patients who underwent prepectoral implant reconstruction using meshed ADM over a 1-year period at our institution. In all patients, the mastectomy flap perfusion was confirmed intraoperatively with indocyanine green angiography. We proceeded with prepectoral reconstruction in patients who had brisk fluorescence on imaging, demonstrated in the photograph. For patients who demonstrated delayed fluorescence or who had mastectomy skin flaps that were less than 8 millimeters thick, we converted to a subpectoral reconstruction. Based on the selected implant size for each individual patient, we chose either a medium or large sheet of contoured ADM. The ADM was passed through a 2-to-1 skin graft mesher, and then this was used for anterior implant coverage, sutured to a sheet of bicoal mesh posteriorly, which was then secured to the underlying pectoralis major muscle. The images demonstrate the anterior and posterior surface of the allograft implant construct, which was always prepared on the back table prior to insertion into the breast pocket. In total, we looked at 71 breast reconstructions in 45 patients. The average age was 46 years old. The average BMI was 27. The average implant volume was 485 cc's, although this ranged widely between 265 cc's up to 800 cc's, and the average length of follow-up was 1 year. In all cases, 1 sheet of ADM was used for each breast, with an average surface area of 164 centimeters squared of allograft per breast. Regarding complications, we had 1 case of a minor stitch abscess. We did have 1 hematoma from an axillary dissection that required operative washout. And we had 2 cases of infection, 1 of which resolved with oral antibiotics, and 1 of which required explantation and ultimately led to a loss of reconstruction. Notably, this was in a diabetic patient who went on to require radiation after reconstruction and also delayed presentation to the hospital. All patients expressed satisfaction with the cosmetic appearance of their breasts. These photographs demonstrate a 1-year result after prepectoral reconstruction with a 520 cc implant and meshed large contour perforated ADM. So you can see excellent symmetry and aesthetic appearance. So in conclusion, the existing literature describes a prepectoral technique dependent on large sheets of allograft up to 320 centimeters squared, whereas our method utilizes an average of 164 centimeters squared per breast. Meshing maximizes cost efficacy by expanding the coverage potential of a single sheet of ADM. Early findings demonstrate a low complication rate, lower than previously reported in the literature for prepectoral reconstruction, and high patient satisfaction. In the current healthcare environment of cost containment, novel techniques must give consideration to sustainability as well as safety and clinical outcomes. I just want to thank all my co-authors. That's it. Thank you all.
That was terrific. Our next presentation comes from University of Wisconsin, entitled "The Regenerative Effects of Reconstruction: An Analysis of Cutaneous Gene Expression Changes in Irradiated Breast Reconstruction Patients." Dr. Gunderson, I believe, is going to be presenting this.
Yep, one moment. Good evening, everyone. My name is Kirsten Gunderson, and I'm a fourth-year medical student at the University of Wisconsin. Today, I'd like to share with you some of our gene expression work titled The Regenerative Effects of Reconstruction. And we have no disclosures. Whole breast radiation is becoming increasingly common for the treatment of breast cancer patients, with recent guidelines advocating for its increased use amongst early-stage patients with minimal axillary disease burden. Despite the efficacy of radiation at increasing disease-free survival, it does come at the cost of chronic tissue damage that negatively impacts the success of our reconstructive options. Irradiated patients demonstrate fibrotic, non-compliant tissue with poor wound healing potential, and it's well known that certain reconstructive options like alloplastic reconstruction are at a high risk of complication and failure in this population. Although we can see these phenotypic features of radiation displayed in our patients, the underlying genetic changes that drive these tissue fibrosis are not well understood. Further, the genetic changes that are induced by reconstructive efforts, such as autologous reconstruction or fat grafting, which appear to improve the overall skin quality, have never been elucidated. Given these remaining questions, our goal in this study was to determine which genetic pathways are most significantly affected by radiation and how these pathways are affected by different reconstructive efforts. To achieve this, we first began by enrolling breast cancer patients who had been treated with or without radiation therapy and who were undergoing mastectomy and either autologous or alloplastic reconstruction in either an immediate or delayed fashion. We also enrolled patients undergoing breast reduction or prophylactic mastectomy as external controls, and patients who underwent radiation on their cancer side but had no radiation on their contralateral side were used as their own internal controls to help account for the underlying genetic changes that may be inherent to a patient with breast cancer. Full thickness mastectomy skin samples were collected at the time of initial reconstruction and then subsequently at the time of revision, approximately 6 months later. All samples were analyzed using RNA-seq technology to determine their cellular transcriptome. And gene expression was then analyzed via hierarchical clustering to identify genes that were significantly up and down regulated by radiation treatment and to discern the genetic impact of reconstruction. In the interest of time, I have limited my presentation of the results to discussion of patients who underwent autologous reconstruction. First, we performed a comparison of irradiated and non-irradiated samples. We used their global gene expression profiles to discern how alike or different each sample was from one another. We're able to appreciate this visually in a multidimensional scaling plot shown here, which is a way to graphically depict transcriptome variation across samples. The ellipses on this image represent 95% confidence intervals, and the minimal overlap of these groupings show that the irradiated and the non-irradiated samples have distinct gene expression from each other. More granular data was then obtained by comparing gene expression levels of each individual gene between the irradiated and the non-irradiated samples. In this heat map of gene expression profiles, samples are listed on the x-axis, and each dysregulated gene is listed along the y-axis. In total, analysis demonstrated that there were 23 genes significantly dysregulated by radiation treatment. Further KEGG pathway analysis of these dysregulated genes revealed that there was major dysregulation in pathways such as steroid biosynthesis and cholesterol metabolism. We then focused our attention on the effects of reconstruction, comparing gene expression profiles between stage 1 and stage 2 samples. This graphic shows samples from patients who underwent radiation treatment and reconstruction via autologous free tissue transfer. This heat map analysis was performed early in the study with one revision sample available. Stage 1 samples are on the left in green across the bottom, and the stage 2 sample is on the right in orange on the bottom. The highly different coloring of the stage 2 sample shows that it has distinctly different gene expression from the stage 1 samples. Further KEGG pathway analysis of these genes showed that the major differences again were seen in cholesterol, lipid, and steroid metabolism pathways. Importantly, these changes in gene expression and the activity of these pathways was reversed from the dysregulation caused by radiation. So if they were upregulated by radiation, they were downregulated after reconstruction with autologous tissue and vice versa. So overall, we had 74 patients enrolled for genetic analysis of irradiated and non-irradiated breast tissue with initial comparisons between benign breast tissue prophylactic mastectomies and irradiated and non-irradiated breast cancer patients. We also analyzed second stage post-reconstructive patients. Our initial genetic analysis demonstrated that cholesterol biosynthesis pathways are dysregulated in irradiated tissues, and that these genetic changes seen in stage 1 after radiation appear to be partially reversed in stage 2. Importantly, this regenerative phenomenon was more apparent in autologous reconstruction than in alloplastic reconstruction. I'd welcome any questions. Thanks.
That was fantastic. I think we have a few minutes to take some questions from the participants. So feel free to either chime in or type something in the chat box. We can relay. Maybe I can start off the discussion, with a question for Dr. Nelson. Fantastic presentation, and clearly, your institution has significant experience with textured implants, and leading the charge as it relates to BIA ALCL. I just wonder, with all this data, how have you changed your surveillance strategy, or do you anticipate a change in your surveillance strategy for patients with implants and patients specifically with textured implants?
Yes, I think it's a great question. Once we sort of determined that this incidence, we mailed all of our patients who had both textured and smooth implants letters detailing sort of our understanding of risk, and offered for them to come in for consultation. I think that given that ALCL typically presents as a delayed seroma, or that's one of the most common presenting signs, I think our surveillance for patients who don't desire potential risk, the concept of risk reduction surgery, which brings up a whole nother idea, is routine yearly examinations. And then certainly just standard FDA recommended MRI screening, I think, is still indicated. I don't think that necessarily doing above that is warranted currently. But certainly it changed our discussions with patients in the in the long-term survivorship period with regards to how to approach this risk and what they wanted to do, knowing that the risk is a lot higher than probably previously thought.
Thank you.
If it's okay, I have a follow-up question for you, Dr. Nelson. I was just curious, was the study designed just to look at patients who were diagnosed with ALCL, or did you actually look at other outcomes? I guess my question I'm particularly interested in is how many patients had chronic seroma, and then what percentage of those patients actually were found to have ALCL?
Right, yeah, the study was designed particularly around the diagnosis of ALCL. So we did not look at the incidence of chronic seroma. Certainly, as you know and mentioned, you're interested in it, chronic seromas certainly happen, and it's common to have some fluid around implants in the long term. And so, probably the majority of seromas are not ALCL, but certainly when fluid occurs and a large seroma occurs suddenly, then it's worth investigating.
The next question comes from Dr. Jaya Palina. It's for Kristen Gunderson. The question is, what tissue types did you use in your study?
Yeah, we used full thickness skin samples from the mastectomy skin.
Yeah. So you didn't look at the muscle tissue or capsule?
We did not. This one was limited to just skin.
Okay, thanks.
Okay. I actually have a question for Dr. Vartanian. I noticed in your construct, actually it was two questions. One, you placed a vicryl mesh posteriorly. I was wondering what does that sort of lend to the reconstruction? And the second question was, do you have any plans to explore sort of the aesthetic differences between using meshed dermal matrices and non-meshed dermal matrices.
Thank you for the questions. So regarding the vicryl mesh, the mesh served a few purposes. It let us use our meshed allograft for complete anterior coverage of even some of our larger implants, because we were able to then secure that acellular dermal matrix to the vicryl mesh to get all the way around the implant, rather than having to fold it all to reach itself. And then secondly, it also allowed us to position the implant where we wanted it in the breast pocket. So we could use tacking sutures between the vicryl mesh and the chest, the pectoralis major muscle and fascia, to prevent sort of lateral displacement in the pocket. And to address your second question, we're still in the early phases of this technique. So I think once we have follow-up data for 5 years or so, then we'll really know the cosmetic results and the true incidence of capsular contracture to compare the actual aesthetic outcomes between groups.
So you're using non-tabbed tissue expanders?
This was a direct to implant cohort for the most part. The only time we would use a expander was if there was insufficient skin laxity to insert the implant, but the vast majority of these cases were DTI.
Thank you.
A follow-up question, if I may, Emma. I'm just curious. I saw several metrics where sort of revision surgery rates monitored. I'm just curious. Yes, you had good primary results, but what percentage of patients actually needed fat transfer as a way to measure whether this is more superior or less compared to alternatives?
That's a great question. I think we're still, again, we need longer follow-up to really get at the core of that, but the only revision surgery that we had was one case of asymmetry between the implants. So we had to revise for that, but otherwise, we've been able to do this in essentially a single stage without multiple revisions thus far.
Okay. Well, everybody, great presentation this first session. I think, out of respect for everybody's time, maybe we'll head on into the second round of papers. If there are some questions still from the first set, we can always go back to those. But maybe we can lead in with the study complications of immediate tissue expander reconstruction in pre-mastectomy breast reconstruction. And Kanad Ghosh is going to be presenting this from Stony Brook.
Hi, everyone. Thank you for the opportunity. My name is Kanad Ghosh. I'm a fourth-year medical student from Stony Brook University. Today, we'll be talking about complications of immediate tissue expander breast reconstruction and pre-mastectomy breast radiation. We have no disclosures. Patients with a history of pre-mastectomy radiation therapy may require subsequent mastectomy and reconstruction. This may come in the way of salvage mastectomy due to recurrence of cancer or prophylactic mastectomy. Thus far, autologous reconstruction has been the gold standard for these patients. However, this procedure is associated with longer operative and recovery times, donor site morbidity, and increased length of stay. A study published in 2012 looked at the use of immediate tissue expander reconstruction for salvage mastectomy in patients with previous irradiation. They found significantly higher rates of skin necrosis and worse aesthetic results in these patients, as well as higher rates of capsular contracture. They're not significant. Importantly, they did not find a significant difference in complications such as infection and tissue expander loss. They concluded that certain patients may be able to safely undergo tissue expander reconstruction even after radiation. The purpose of our study was to further characterize complications associated with pre-mastectomy radiation therapy to evaluate which demographic factors have higher association with complications in these patients. This was a retrospective chart review using REDCap software of patients who underwent a reconstruction at our institution between 2001 and 2017. Comparisons were made between patients with a history of prior radiation versus those who had not undergone prior radiation, as well as comparison of patients within the radiated cohort who had infection, reconstructive failure versus those who did not. Minimum follow-up was 1 year, and cases of delayed reconstruction and autologous reconstruction were excluded. So there were 54 patients who underwent pre-mastectomy radiation therapy and 624 who did not. We found that the former group was significantly older. However, there are no other significant differences between the two. When we looked at complications, we found that patients with prior radiation had higher rates of implant loss, infection, skin necrosis, and wound dehiscence. However, for our patients, these differences were not yet significant. We then looked at the 54 patients who underwent pre-mastectomy radiation therapy and looked at the time from radiation to reconstruction. There were 8 patients who had reconstructive failure and 9 patients with infection. We found that on average, patients with reconstructive failure and infection had a shorter duration from radiation to reconstruction than those without these complications. Again, these values and these differences were not yet significant. We then looked at demographic associations with infection, reconstructive failure, and skin necrosis, and found that hypertension was significantly associated with reconstructive failure. Lastly, we looked at the cohort of patients who were radiated and divided them up by which breast was radiated or not. So there were 58 irradiated breasts versus 39 breasts that did not receive radiation. Again, we saw an increase in implant loss, infection, and wound dehiscence amongst the irradiated cohort. Again, these values were not significant. However, we did notice a significant increase in skin necrosis in breasts that underwent radiation, which is in line with previous studies. So in conclusion, we found that patients with a history of pre-mastectomy radiation therapy had increased complications, though not significant. Pre-mastectomy radiation therapy patients with subsequent reconstructive failure or infection had shorter times from radiation to reconstruction, though again, not significant yet. Pre-mastectomy radiation patients with hypertension also had significantly increased risk of reconstructive failure after reconstruction. And lastly, comparison of irradiated breast versus non-irradiated breast showed significantly increased skin necrosis in the former. So tissue expanded breast reconstruction may indeed be a safe option in certain patients with a history of prior radiation. However, our study is limited in its retrospective nature and the number of patients, especially within the radiated cohort. These are our references. Thank you for your time.
Okay, very good, thank you. Our next presentation will be contralateral prophylactic mastectomy and breast reconstruction trends, a 10-year review at a tertiary care center by Harsh Patel.
Thank you. My name is Harsh Patel, and we'd like to thank you for the opportunity to present our work on contralateral prophylactic mastectomies and breast reconstruction trends at our institution. We have no disclosures. So contralateral prophylactic mastectomies, or CPMs, the trends have been changing over the decades with multiple factors that have been identified that influence patient decision-making. Despite the literature showing no survival benefit for these patients, women still elect to undergo this procedure, which begs the question, are there other psychosocial influences that underlie their decision-making? Our study aimed to elucidate possible factors that may influence patient choice for CPM. We did a retrospective EMR review from 2008-2018 of all of our patients that underwent surgery here. Key exclusions were bilateral disease, genetic risk factors such as BRCA positivity, bilateral prophylactic surgery, and patients managed surgically at outside institutes. Out of 5,000 patients, we tailored that down to 953 after all exclusions. And we're left with 554 CPM patients and 409 unilateral mastectomy patients. We assessed over 25 variables in each of these patients. So let's begin with the annual trends that we noticed. The number of patients undergoing mastectomy annually increased and plateaued around 2013, after which an average of about 104 mastectomies were performed yearly at our institute. Separating the CPM cohort from the unilateral mastectomy cohort, we noticed that CPM rates were consistently higher than unilateral mastectomies until about 2016, at which the point the trend actually reverses and patients begin to elect more for unilateral mastectomies more frequently. We then looked at our peaks, which we noticed were in 2009 and 2013, and looked to see what other things may have influenced that. And we found that highly publicized celebrity events such as Christina Applegate's surgery at the end of 2008 and Angelina Jolie's at the beginning of 2013 correlated with our peaks, which points to at least one factor that may influence patient decision-making. We also looked at the trends of age and uncovered that patients that elected for CPM were actually younger overall than patients that selected for unilateral mastectomy, which were older on age. This difference was found to be statistically significant. Additionally, we looked at the ethnicities of all our patients. We found that 62% of Caucasians and 52% of African Americans opted for CPM, while only 36% of Hispanic women and 34% of Asian women did so. There was a statistical significance when comparing the Caucasian group to the Hispanic and Asian group, and when comparing the African American to the Hispanic and Asian group, but no such difference between the Caucasian and African American group. This led us to wonder if this was a indicator of a potential healthcare disparity. And so the next we went on to look at insurance. On the left is a breakdown of CPM, and on the right is a breakdown of unilateral mastectomy patients. What we noticed is that even when we controlled for age, unilateral mastectomy patients were predominantly Medicare patients, while privately insured patients went more for CPM. We calculated odds ratios and noticed that patients with private insurance were more likely to undergo CPM, while patients with Medicare or Medi-Cal had lower odds of undergoing CPM. Looking at the factors that specifically correlate to CPM, we noticed when we compared age, ethnicity, and insurance status, we noticed that Caucasian patients that underwent CPM predominantly had private insurance, which was statistically significant for all ages in that cohort. This also is true for the Hispanic population, although younger Asian women with private insurance were more likely to get CPM, while this cannot be said for the same for the older Asian patients. Patients that underwent CPM also were more likely to undergo reconstruction when compared to their unilateral mastectomy cohort. And we then looked at what were the specific types of reconstruction that these patients elected for. And we noticed that although breast implant-based reconstruction was the most popular in both cohorts in the immediate setting, CPM patients were actually significantly less likely to elect for autologous reconstruction when compared to their unilateral mastectomy cohorts in age-matched grouping. Additionally, all ethnicities were more likely to opt for reconstruction, Caucasians with the highest rate of reconstruction and Hispanics with the lowest, although there was no statistical difference between these groups. Overall, in conclusion, CPM trends are changing, and this has been known for a while, but there are additional variables that haven't been described in the literature that we look to assess. And one of the biggest ones that we found were the impact of social media and the media on that. But additionally, the groupings with regards to insurance have also been changing. With this, we conclude that further studies are required to expound really why CPM patients show differences in reconstructive choices. Ultimately, understanding these trends would allow surgeons to optimize patient education and minimize healthcare disparities for management of breast cancer. I would like to thank you for the opportunity to present.
Thank you. That was great. Our next presenter is from University of Utah, Dr. Jayapolina, on micropattern surfaces limit fibrous capsule formation around breast implants, a pilot translational study.
Can you see my screen?
Yes.
Sorry. First of all, thank you for the opportunity to present. I also want to acknowledge my collaborators and co-investigators, Dr. Shea and Dr. Agarwal, for their input. And this is not a clinical study, it's a basic science, so I'll try to make it clinical as possible. As you all know, breast reconstruction is commonly performed plastic surgery operation, and there are many concerns, but mainly infection, capsular contracture, and cancer. And we touch upon cancer earlier on this set of presentation, but infection happen approximately about 15% of the cases. However, capsular contracture is much higher. They are reported papers saying as high as 50% of the patient will have capsular contracture formation. and it's associated with mainly the smooth implant surface. If you just look at the ALCL data from FDA, you can see that mainly the textured implant, patient with textured implant reported ALCL cases, and also it's made by only mainly the two type of manufacturers. Even though implant looks clean to a naked eye, but if you put it under the microscope, you can see the porous or the textured silicone and polyurethane implants got ton of debris inside the pores. So we thought it may be a contributing factor for ALCL. So the question is, can we make the smooth implant to have a different tissue reaction and produce thinner capsule, non-contractural thinner capsule? So what we thought of is like looking at the nature uses micro patterning to change the surface properties. We also know in chocolate technologies that you can not only limit the bacterial adhesion to the surface, we can also alter the surface of this material to surface contact, and also how well the liquid spread on the surface, as well as the fibroblast or any other cell type of interest, adhesion and proliferation. So what we did was we made 4 different type of surfaces by changing the nanostructure within the microstructure. So the nanostructure is this post on the lower left-hand side of the screen. And we changed the A, which is the width of the post, and the B, which is the distance between the post, and made 4 different type of surfaces. And we used that surfaces and checked how they respond to the biofilm formation on them, as well as the cell culture. And after that, we did 2 rodent in vivo studies. So first of all, when we put these surfaces in a biofilm reactor and we use the positive control, and you can see on the positive control, we know there's a ton of bacteria will adhere to it. We do see a ton of bacteria, but when you have a surface, the chocolate type surface with the narrower pillars, you see relatively lower amount of bacteria adhere to them. Also, we change the depth of the pillar and see whether we can see any changes, especially when you have the depth, which is 4.5 micron deep, and 3 by 3, we've seen 4 log-fold reduction in bacterial adhesion. And taken the same surfaces and we put the fibroblast and grown it over 48 hours, you can totally see most of the shallower surfaces did not have any significant difference between the smoother, non-patented silicone. However, anything above 4.5 micron, you had a higher amount of statistically significant amount of cell adhere to the surface. So we picked 3 by 3, 5 by 5, and 10 by 10 with a depth of 4.5 micron to test it on a red back model. So we made this surface design on silicone implants, and then we insert in the back of the rats, and you can clearly see at 4 weeks there is no capsule formation was noted. However, on a control surfaces, we have seen giant cells, whereas each surfaces have different response. When we stain it for the macrophages, we saw control, and 10 by 10 had a higher count of macrophages, which is indicated by the blue dots. The second experiment we did, we kept this implant in this animal for 12 weeks. And at the end of the 12 weeks, you can see the capsule was formed, and we don't really see much of a tissue reaction to it. The important thing is when you have 5 by 5 design, the capsule was thinner, almost 75% thinner than the smooth control. So in conclusion, what we concluded is, yes, it is possible to limit the capsular contracture formation around smooth implant by applying micro patterning. And also we can, by changing the design, we can also change the tissue responses to these implant surfaces, and we can also tailor make the implants. Thank you for listening, and I'll take any question later on.
Marco, I think you're muted.
Sorry about that. Our next abstract will be by David Nash from Montefiore Medical Center, estimating blood loss and abdominal-based breast reconstruction. How accurate are we?
Guys, can everybody see? Okay. Hi, everyone. I'd like to thank the PSRC for this very exciting opportunity to present our research. I have no disclosures. So in patients undergoing surgical treatment for malignancy, perioperative blood transfusion has been shown to negatively impact both short-term outcomes and patient survival. This is relevant to microsurgeons as free tissue transfer has the highest transfusion rates within the realm of breast reconstruction. In an effort to mitigate these risks, our aim in this study was to evaluate a surgeon's accuracy in estimating blood loss in abdominally based breast reconstruction, and to identify the factors that can help predict postoperative blood transfusion. To do this, we conducted a retrospective review of all patients that underwent abdominal-based microsurgical breast reconstruction at a single institution over a 10-year period. Patients were excluded from the analysis if they required intraoperative blood transfusion or developed a hematoma. But before determining the surgeon's accuracy, we first needed to devise a way to figure out the actual blood loss. We accomplished this by modifying the allowable blood loss formula, or ABL. This is a validated estimate of intraoperative blood loss at which a transfusion should be considered, and it's routinely used in the anesthesia literature. Our modification exchanged the hematocrit at which a transfusion is considered with the immediate postoperative hematocrit. In doing the substitution, it allowed us to more accurately calculate intraoperative blood loss. Having determined the actual blood loss, we could then proceed to determine the accuracy of our surgeon's estimates. We did this by calculating the percent difference between the actual and estimated blood losses. In total, we analyzed 286 patients. Their baseline demographics were well matched, and they had similar hematologic risk factors. The median estimated blood loss was 300 cc's. In keeping with the rates that have been previously reported in the literature, we had an 18% postoperative blood transfusion. When we put our estimations to the test, we found that on average, surgeons underestimated blood loss by 67%. Or if you want to look at that a different way, they were off by approximately 2.5 units of packed red blood cells. They were equally inaccurate regardless of whether the patient ultimately was transfused. In further examining the transfusion groups, We identified several perioperative factors associated with the transfusion. You can see those here highlighted in the table. These associations allowed us to utilize a logistic regression analysis and a receiver operating characteristics curve to design a model that could predict blood transfusion. Over here on the left side of the slide, you can see the results of that regression analysis. The next step was for us to examine a cutoff point so that we could translate the regression results to a dichotomous outcome. That's a fancy way of saying that we took the cutoff point and allowed it to, in determining the cutoff point, we were able to take the regression result and make a prediction about whether a patient will require a transfusion. A cutoff point of 0.22 was selected for its high combined sensitivity and specificity. Now, I realize that this may not necessarily be intuitive, so here's an example of how this works. Say a patient underwent a unilateral non-stacked deep flap reconstruction, and they had the perioperative characteristics that you can see listed there on the left side of the screen. Following the regression analysis, we arrive at a probability of 0.04. And because 0.04 is less than our cutoff of 0.22, we would predict that this patient would not need a transfusion. In conclusion, surgeons significantly underestimate blood loss in patients that receive abdominal-based microsurgical breast reconstruction. This may lead to delayed identification and treatment of acute blood loss anemia, and ultimately lead to adverse effects with regards to patient outcomes. To combat this, we have designed a prediction model that allows for early identification of patients that will require postoperative blood transfusion. Our focus going forward is on creating a web-based calculator that will make our model more intuitive for use. And we are also interested in determining the effects of hemodilution on microsurgical breast reconstruction. This was a limitation of our study, and presently there is no surgical model that exists that can account for the cacophony of factors that influence blood volume physiology. Before I finish, I'd just like to acknowledge my awesome supporting cast. Without them, this project would not have been possible. And again, I'd like to thank the PSRC and all of you for your kind attention.
Excellent. Thank you. So our last presentation is going to be entitled, "Is the Vectra 3D Imaging System a Reliable Tool for Predicting Breast Mass?" This is from the University of Wisconsin and Mount Sinai, primarily from Mount Sinai, and Dr. Casey Wood is going to be presenting.
Hi, thank you very much. So my name is Casey Wood. I'm currently a second-year medical student at the University of Wisconsin, but today I will be speaking about research that I conducted at the Mount Sinai Hospital. And I'll be talking about the use of Vectra 3D imaging system in preoperative planning and prediction of breast mass. We have no disclosures. So I'm certainly not the first to mention today that breast reconstruction is a very common procedure. More than 100 cases occurred just in the year 2018 alone. And historically, preoperative planning for these operations have relied heavily on two-dimensional measurements that would be conducted by the surgeon beforehand. However, in recent years, there has been increasing popularization of 3D surface imaging modalities, and there are many out there. They rely on the use of cameras or lasers in conjunction with computers to just surface the breasts, and then they can calculate the mass in that way. And one of the more popular systems that's available is the Vectra XT 3D camera system. However, at this point, there is still limited research addressing the accuracy of this camera system and its ability to predict breast mass. So given this background, our group posed a question regarding whether the camera's accuracy was reliable, and based off of that, are there common physical characteristics that patients present with that could affect the accuracy of this system? And the characteristics that we were particularly interested in were ptosis and obesity. Our investigation began with retrospective chart review of patients that underwent mastectomy between 2015 and 2019. Variables of interest included the predicted breast mass by the Vectra camera, or VPM as it will be listed in some of these charts. Mastectomy specimen mass was also collected, and that's measured intraoperatively. And then for each breast that was included, the ptosis grade and the BMI of the patient was also recorded. And our statistical analysis primarily relied on the calculation of two-tailed Pearson correlation coefficients to determine how well the predicted mass and the actual mass correlated with one another. And then variances among the data points was assessed with the Bartlett's test. And for each of the subcategories of interest, so those are the ptosis and obesity categories, we assessed how correlation was affected in those groups, and I'll go into depth on that in just a moment. So all in all, we ended up with 201 breasts that were included in this analysis. And each breast is represented by a point on this scatter plot. It's fitted with a line of best fit, and the gray area represents the 95% confidence interval. Overall, including all breasts, the correlation coefficient was calculated at 0.9 with an associated p-value that was well below 0.05. So essentially, this is telling us that VPM is quite predictive of the actual mastectomy mass, and that this calculation was reliable given the small p-value. And using the line of best fit, we derive a simple equation to correct for any internal error that the machine might have. And we found that if you are to take the Vectra predicted mass and subtract 42 grams, that will give you a more accurate number as to the actual mastectomy mass. And this really makes sense because the majority of these mastectomies were skin sparing. So it's pretty logical then that the camera is slightly overestimating what the actual mass of the mastectomy specimen ultimately was. And we conducted a Bartlett's test, which came positive for heteroscedasticity. And essentially what that means is that as one progresses along the x-axis, and I think that you guys can see my cursor, but you'll notice that the points along the line of best fit begin to fan out. So that's to say that the variances between the data points is increasing. So in plainer language and more relevant to this is that as mastectomy mass increases, it appears that the predictive power of the machine goes down. And our next step of analysis was that for each subcategory of interest, so that's all of the ptosis grades and each category of BMI, we made scatter plots of just those breasts included in that subcategory and calculated the correlation coefficient. And these correlation coefficients can actually be converted to z-scores so that we can compare to the overall correlation coefficient of 0.9 that was calculated when we were looking at the entire cohort. So overall, its predictive power remained quite reliable. However, in the case of pseudotosis, we did find that the ability of the machine to predict breast mass was significantly decreased, going down to 0.75. So overall, this is the first analysis of the influence of physical characteristics on the reliability of the Vectra 3D camera system. There has been prior investigation into this imaging modality. In the past, it has been found to be reliable and overall adequate for clinical applications. Another researcher found that there is some limited application in predicting the absolute breast volume. So we believe that our investigation kind of takes these findings one step further in that we identify the specific characteristics that may mitigate the machine's accuracy. The strengths of this study are the large cohort of 201 breasts, and we thought that we got a really good representation of shapes and sizes, which is definitely helpful for our purposes. And overall, we conclude that the reliability of this machine in general has been confirmed. However, it's important to keep in mind that ptosis may mitigate the accuracy of the Vectra system. And future outlook, it could be interesting to see how this might influence surgical decision-making. Additionally, perhaps having a really good imaging system, it might be helpful with operative planning and therefore reduce operative time. And additionally, a lot of these interfaces come along with 3D outcome simulations, which the clinician can use along with the patient, and that might translate into improved patient satisfaction potentially, although these are still areas that would require additional research. So thank you very much, and thank you to the PSRC for inviting me to speak today.
Very good, thank you, Casey. Well, we invite those viewing to chime in with questions through the chat room, but we'll go ahead and just get started with a couple questions. My first is for Harsh Patel. Thank you for your presentation. Just a couple of questions. You mentioned some of your ideas for why the trend of contralateral prophylactic mastectomy increased at a couple of data points. Any particular ideas why it decreased? And I believe 2017 was your inflection point. What are some things in your group's mind that are contributing to that inflection point?
Yeah, so thank you for the question. So one of the things that we did after we put together this thing is to kind of go back year by year and see how things have changed. And some of the other things we looked at is which surgeons at our institute were recommending CPM versus not. And we noticed that one of the surgeons had a huge change. One of the ones that did the majority of the mastectomies had a change. And I think that was around the time when we asked them that correlated for them was they really started to believe that the data for CPM not having survival benefit was valid. And so they started to change kind of the consult appointments with their patients and kind of, made a more well-balanced thing. And I think that's kind of what we're going for at the end of it, is that we need to give patients all their options and kind of equally explain them and to give them the data that we have so that they can make a more informed decision at the end of the day.
I have a question for Dr. Nash. Great presentation. Personally, as a surgeon who essentially practices bloodless surgery, I'm not really sure your study is applicable to me. But if it were, can you just explain a little bit more about sort of the issue of hemodilution, and in your calculations, I know that you take the intraoperative fluid into account. Are you taking the postoperative fluid into account? And when is the time point that you're measuring the hematocrit postoperatively? And the second sort of question, as it relates to the predictive model, what have you built into your model so far that sort of is in the indication of this, or the set of indications for blood transfusion? Because I think that maybe those indications aren't the same for every single patient.
Thanks a lot for the question. We all strive to be a lot more like you, Dr. Schwartz, with practicing bloodless surgery.
Right.
So to address the first part was, remind me again. Now made my own joke and forgotten what you were asked the first part of the question.
Yeah, no. The first part of my question was about the hemodilution, which you acknowledged was something that you were looking more into. But I just wanted to learn a little bit more about, in the current calculations, was it only intraoperative fluid? Was it perioperative fluid? Postoperative to postoperative day one on the floor, and how did you do that?
Right. So with regards to the actual predictive model, the majority of the factors either were preoperative known factors from the patient, or intraoperative factors. So for example, the intraoperative factors were the IV fluids, the colloid, the volume of the IV fluids, the volume of colloid that was given. The EBL was estimated as part of this. There are 7 different components to the predictive model. In terms of the the hematocrit, the timing of the hematocrit was, our preoperative hematocrit was at the preoperative evaluation, meaning that actual time point varied between patients. So whenever the patient was seen in the preoperative setting and the outpatient setting, they ordered their preoperative labs, et cetera. That was the whatever one that they had, hematocrit they had most close to the operation, that was the preoperative one. In terms of the postoperative one, we routinely get a postoperative CBC in the PACU on all of our patients. So that CBC was from the first set of labs in the PACU. And with regards to hemodilution, it was the big headache of the study design for this project. I realize that one of the limitations of it in particular is in the estimation of or in assessing the accuracy of estimated blood loss. There's no good model that we could find that we could apply to our model in order to try and account for the hemodilution effect, and that's something we're looking at going forward.
Okay.
And the second part of your question, go ahead.
Yeah, sorry. No, I just want to make sure that you recall that it had to related to the actual indications that are incorporated into your model for transfusion.
Right, and I think that, like you alluded to, did vary in between surgeons, but in general was a hemodynamic instability, meaning tachycardia, hypotension, and a hematocrit or hemoglobin rather that was under 7, at or either around 7 or under 7 were in general the indications for transfusion in our patients.
Got it. Thank you. Great job.
Thanks a
lot. One question for me, I think maybe for today, we'll go ahead and wrap up just for time's sake. This was for Kanad Ghosh regarding your radiation breast study. I was curious, I think we've all seen relative success with placing implants in previously radiated wound beds with modest success, but I think a bigger question is what are their long-term results and whether or not they need to convert to autologous reconstruction. Was your study just limited to, I don't know, 30 to 90 days or so? Did you actually follow these patients longer to determine that there was a significant conversion rate from the radiation group to autologous reconstruction versus the non-radiated group?
Absolutely. Thank you so much for your question. So the minimum follow-up for our patients was 1 year. The average follow-up was 15 and a half months. So there's definitely room to keep following these patients, and we definitely plan on it. In terms of conversion, from conversion to autologous reconstruction, there was only amongst the 8 patients that had reconstructive failure in the radiated cohort, only 2 of them were converted to autologous reconstruction, and that was counted as an implant failure.
You didn't account for patients who might come to the office electively and say, I have asymmetry or I have a tight constricted skin envelope, things of that sort?
In terms of the reason for
wanting to convert?
No, those patients would not be included.
Good. Wonderful. All right, I don't know if there are any additional questions.
Well, thanks to everyone who presented. It really was a great session and great to hear what everyone was working on. Thanks to Marco and Graham for being the moderators for this. And I just want to remind everyone that we have 3 more of these breast sessions on Thursday, and then next Tuesday we have a group of panelists on breast reconstruction experts. So I encourage you to listen in on those, and then we have another best paper session coming up the following Thursday on the 24th. And after the session on the 24th, and stay now if you can, we're going to have a mentoring session for about half an hour or so for the residents or really anyone interested who's on. We've got a great group of surgeons on from various parts of the country, different parts of their careers, different specialties, and this is an opportunity for residents and medical students to ask questions, pick our brains, and one of the best things about meetings that we aren't getting to do right now is to hang out after the meeting at the bar and get a chance to interact with all of you. And so this is kind of our virtual way to do it. If you want to grab a glass of something to drink along, please stick around and ask questions of us. As I look through the list, I see we've got Dr. Schwartz, Dr. Ellis already, and Dr. Hassanian, Dr. Snyder-Warwick, Dr. Bowie, Dr. Agarwal, Dr. Lee, and I'm sorry if I missed anyone else who volunteered their time to hang out with us. So thanks to all of you for being here, and if you want to kind of switch to the gallery view so you can see everyone, and if there's anyone who wants to ask us any questions, we're here for another 25-30 minutes. Thanks, everyone.
Great. Well, how's everybody doing tonight?
Hi, Allison.
Hi. Those were really nice talks. Congratulations to all the presenters.
So Allison, since you're on the call and since you are on the board of PSRC, maybe I can put you on the spot and you can talk about some of the things that we can look forward to, which at our next meeting, which hopefully will be in person.
Yes, we are all really hoping we can get together for the next meeting. So I think one of the things we're really looking forward to is highlighting some innovation in plastic surgery, which is one of the best parts about our field. So there was going to be a bit of an experience, sort of like a Shark Tank type of experience where people could submit their ideas and get some creative feedback on those ideas and then make it into a fun competition for everybody. So hopefully it's win-win for everyone involved. So I know we'd like to continue to do that next time. And we are looking forward to highlighting, of course, a lot of the great science going on in the specialty, meeting a lot of young people who are interested in plastic surgery or who are just getting started in their training for plastic surgery. That is, for anyone new to the PSRC, that's one of sort of the hallmarks of this society is it's a bit of a younger crowd, and we really want to emphasize the ability to interact with folks like we're doing right now, but hopefully it'll be in person. So, and there'll be much, much more in the program that we put together for next May. Fingers crossed.
And where's the meeting going to be in May?
Cleveland.
All right.
Cleveland rocks. Cleveland rocks.
Yep.
Yeah, and there's going to be the Rock and Roll Hall of Fame, of course, is in Cleveland, and you know, you can all look forward to checking that out. It's a really fun experience if you've never been. There's some interactive parts, and yeah, it should be, of course, a great time. But it's really the people that make the party, not the place. So we look forward to seeing all of your faces there. Everyone's so quiet.
I know. We don't have enough
Maybe we could start out asking if any of the fourth-year med students are here and how the process is going so far applying for residency.
Hey, I'm a fourth-year medical student, Stony Brook University. It's been a pretty weird few months, but I think overall, like ACAPS has really been helpful and supportive in terms of the meet and greets that have been happening. And overall, like residents and faculty have been really responsive to emails. So, you know, I definitely think it could be worse. So I think it's going.
Yeah, I agree. I think everybody's just been kind of like making the most of it. And something that I've been trying to jump onto is trying to follow everybody's Instagram now, because that seems to be where everything is.
And have you guys done sort of more sub-Is at your home institution then, or just I guess just less, plastic surgery rotations than you would have done in the past because you're not going away for sub-Is?
Yeah, I was able to do my home sub-I and a few more weeks of plastic surgery as an elective, as well as like some general surgery electives. Just to kind of take up the time that I would have been doing aways this summer. So it's worked out pretty well, I think.
You guys feel like you've been getting a sense for like what the different programs have to offer? Are you all getting the information you need to make the big decisions you guys are going to have to make in a couple months?
I think the most helpful part of a lot of the meet and greets have been, when the residents are kind of one-on-one with the students. It kind of helps to, just not evaluate just only like the academic or the clinical merits of the program, but also aspects of living in whatever geographic region, or how the residents are getting along and things like that. So I think that's been a really important part.
By the meet and greets, do you mean the ACAPS ones? You found those useful?
Yeah, for the most part, definitely.
Yeah, I think I would echo that too. I think the biggest thing that we're gonna miss, other than like feeling a fit for a city, is just like getting to know the residents and having that opportunity to interact with everybody, the night before an interview, and really pick everybody's brain. So I know in some of the ACAPS meeting groups that I've gone to, I've appreciated when they've broken it out into like one resident and a couple students, versus the giant, there's 100 people logged in and nobody's really asking questions.
Well, at least you guys will save a ton of money on interviews. That's the silver lining.
Absolutely.
Yeah, I think when you think about so many things that you're kind of bummed about, try to think of some of the good. And I think you guys know a lot more about programs this year than any other class has going into interview season, because there's just so much information out there, and you can access things that perhaps you may never have known about a program because you wouldn't have had time to check it out. So that's one good thing, but I know it's so hard to not be there in person and meet people one-on-one.
What are some of the other things that the students that you guys like during the meet and greets? We happen to have one coming up here at the end of the month here at Montepere. So, and I'm sort of in charge of putting it all together. So I'd like to hear what kind of has worked in the past and what you guys think could it be improved on.
I think I personally kind of appreciate hearing, in terms of the faculty portion of it, just hearing from a few different faculty members, especially, members who might concentrate or focus on different fields, or people who are more focused on global health, people who are more academic. So it's nice to get kind of a balanced kind of approach to the whole program, as opposed to just one faculty member or the program director only talking. So yeah, I feel like that has helped in the past.
Yeah, I agree. I think something that stood out to me too is when there's a lot of faculty and residents who are actually attending it. There are a couple that I've gone to where it was just the program director or just the chair giving their talk, and I think it means a lot when you have all of the faculty like behind you, like putting their time into talking to us as well.
Thanks for the feedback. I will show up in numbers and will be very participant at Montepere. And set up some sort of more one-on-one directed stuff for you guys. So hopefully you'll be joining us.
Just want to chime in about,
Oh, sorry. Go ahead.
No, go ahead.
I was just going to say, so we have 2 fourth-year medical students, and maybe if other people could go around and tell us what year, what level you are.
So I'm a general surgery resident, interested in playing independent track. So seeing the, like on Instagram and things like that, the networking opportunities virtually, a lot of them are geared towards the fourth medical students, which is absolutely fine. Just wasn't sure if should the independent applicants also just jump into those spaces and participate. Obviously, if there's an independent program available at that institution. Any thoughts about that?
Are you applying this year for plastic surgery?
Next year.
Okay. Oh, as in like, okay, this academic year?
The next one.
Oh, okay. Yeah, I'm not sure. That's a good question. I thought the ACAPS thing was sort of focused for, especially timing wise, now it being like early now, for the integrated applicants in general, but I'm not directly part of ACAPS. I'm a microsurgeon at Indiana University, and we're doing the meet and greet thing, I think in a couple of weeks or so. I'll be part of that, but more than that, I don't know too much more detail, but I think it's for integrated, but I imagine it'd be fine to jump on in and, find out about the program.
Yeah, I agree. I think the more information you can get, the better. But I do know that a lot of places are sort of limiting spots to the applying students this year, just because there are limitations on even virtually how many spots you can have based on your Zoom license and things. And they didn't want people this year to miss out when, it's immediately relevant for them. But whenever those restrictions aren't there, then yeah, absolutely. The more information you have, the better informed you can be. That makes sense. Right?
Are there any other students or future applicants on tonight?
What about residents?
So I'm a 6-year resident here in Montefiore, applying actively in the midst of the micro match.
I'm a 5th-year resident at USC, and I actually had a question in a similar vein for the faculty that are here, sort of for residents who are looking at fellowship coming up, which, is kind of a brief but intense commitment for both the institution and the incoming fellow. How has the virtual interview experience been, and do you feel like you get a sense of who would be like a really good fit for that 1 year to train?
I can start answering this question. So we actually just had a paper accepted into the Journal of Surgical Research where we had the independent applicants, because at Indiana University we have both independent and integrated. We had one interview session where it was, in person for the independent, and then that was right when COVID happened. And the second one was integrated, and we sent surveys out. And not surprisingly, the residents it got much worse scores at the virtual interview. They just thought they got less of a feeling and less of a taste of the program. From my personal experience, being an interviewer, it's a little more awkward. There's more sort of silent pauses. It's kind of harder to read people. So it's definitely not ideal. I mean, but the amount of money and costs saved is a huge added bonus, I think. And as faculty, it's probably, less of an issue because realistically, you're just meeting people for a handful of minutes, 15 minutes, 20 minutes during an interview. It's better to do it, it's better to read people and do it in person, kind of get to know people better in person. But I think for the applicants, not seeing the city, not directly interacting with the residents is probably a bigger deal?
Yeah, I would echo that. We just we had our recent microsurgery interviews virtually, and I felt as though it was better than I anticipated it would be. I think that we're probably lucky that some of these interviews are coming well into this whole scenario. So it's not everybody's, the technology is not unbelievably fresh for everybody. They kind of know a little bit more how to maybe interact virtually. Despite some of the minor glitches that we had in terms of conversations getting cut short, I think that it's going to be a manageable process for everybody, this year. Hopefully it will go and revert back to normalcy. But, for a year, I think it's going to be fine. And I think that part of the actual interview process for, at least the faculty gauging the fit of the applicant, I think that it can be done to some extent. It's definitely not ideal, but I feel like we had a successful, a fairly successful foray into this. So I think it bodes well for residency interviews for everybody.
One thing that might be a little different, though, is the general history of the numbers game, because in the past, applicants were limited by where they could physically go and travel between cities. Now I imagine applicants, you guys probably should be accepting whatever you can, as long as it's on the same day. I mean, if you're applying for the program, I imagine there'd be no reason to turn it down. And so, the numbers for med students in the past, I think people would say, and for independent residents, if you do X number of interviews, 15 or whatever, then that's a good number to match, or whatever those numbers were. But that might all change if people are doing sort of more interviews, and programs might need to interview more too. So I don't know how it's all going to play out. I mean, certain things are beyond our control.
I guess I can chime in from the other side of the equation. I think that, I had a couple fellowship interviews right when the pandemic hit, and we first started going to all virtual. And not surprisingly, those interviews I felt were not quite up to the round that we're currently going through right now. I think that's because, in the interim and in delaying the whole match process, everybody was able to get much more facile with the technology and come up with a fairly bulletproof strategy of how to actually pull this off. And so I think that, there's certain, I'll echo what everybody else is saying, that it's not the same and it's not the ideal way of doing it. But I think if there is a second best ideal way of doing it, I think this is probably it. Some things I've liked from the most recent crop has been that they've kept all the applicants in a green room and kept that unmonitored, so that the applicants can kind of get a sense of camaraderie. I mean, it's not like going out to the bar and having a couple of beers and talking about the different programs and stuff, but it's about as best as you can get under the circumstances. I think that the faculty have done a really good job of trying to be targeted in their interviewing, and I feel like I've gotten a fairly good sense of what the programs have to offer, and in general, the kind of personalities that are there, which has been great. And so I think that, you take a step back and think about how much time you're actually spending with the people while you're interviewing. It's about the same as it normally would be. Now, you may not get you may not be so attest to the different nonverbal communications that happen, but you still pick up a fair amount on Zoom. So I think it's been pretty good. And if it persists, if it unfortunately persists and spills over to next year, I think it will be even better. And for the medical students, I think that it's going to be a pretty straightforward and relatively easy process, particularly with the generation that's so in touch with technology as is. It'll be harder for the programs, not for the medical students.
I had a quick question. Do you know if, before the interviews, it would be like pretty much the entire day plus time allotted to travel and things like that. I was wondering, now that it's virtual, is there a talk of having kind of like, are the interviews going to be shorter, or is there any notion of like doing first and second round interviews? Is that a thing?
Well, my guess is that, like at our institution, a lot of institutions are still working out the details. Haven't quite figured out how those days will run, minute by minute.
Okay, got it. Thank you.
Yeah, similar at my institution. They were still trying to figure it out, but there's no plan to do a second round. Definitely not that. And then in terms of the length of the interviews, there's no plan to change the length of the interviews at this point, but it's not set in stone.
Yeah, the one tip that I would give you, and clearly I haven't figured this out yet, but I think that concluding the interview is, as much for me as the interviewer and probably for the applicant, trying to kind of wrap up your final statement, because there's no walking out the door in these interviews and sort of saying your goodbyes. At least the way we wound up structuring it, and I can't see a different way to actually do this, since there's got to be a coordinator who's kind of bringing people in and out of the different virtual rooms and so forth. So it's a hard stop, and it might be mid-sentence. So I think that just as like a little tip, if you can figure out a way to wrap up concisely, or get your interviewer, if we're talking, just tell me to, stop talking, when you see the timer, type of thing. So that's just my little aside from these virtual interviews.
Thank you.
Is there anyone else that has any questions or anything?
I have a question. It's not related to the application process. It's more so towards, if I remember last year, there was opportunities for PSRC mentors. Is that still, I know it's probably virtual, or is that still available, or?
You mean getting matched with the mentor?
Correct, yes.
Yeah. So as part of the mentorship committee, we still had that. So if you don't have a mentor that you're matched with, then yeah, we'd be happy to find you one. You could email me or email Sarah Boardman. I can give you my email if you have a pen and paper. AHASSANE@iu.edu. And I can get you matched to a mentor.
Okay.
Yes, and it's a great time for us to advertise the mentorship program too. And I was thinking I should have mentioned it earlier, and I was trying to remember before we got off the call, but this is a good time to do it. So if anyone's not participating in the program, please, reach out to any of us or to Sarah Boardman, and we'd be glad to get you enrolled. And then there is the mentorship webinar is coming up in October. Is it October 19th, Al? Is that right?
Either 19th or I think the 19th. Let me just tell you in 1 second.
Okay.
You got my calendar.
No, it's the 26th, October 26th.
Week off. Okay. October 26th is the mentorship webinar, and Susan McKinnon And Bernie Lee will be speaking. Be a great event, so you guys should tune in for that.
Hi, team. How's it going?
Hey, Justine, how are you?
I'm on 2 Zoom calls, so sorry I'm so like out. How's everybody?
Great.
Good. How you doing?
I'm good. I have no mentorship questions. I just want to say hi.
I thought it was unlike you to not have your camera on.
I know, I'm sorry. I feel bad. Like I wanted to support and stuff, but I'm like literally, we have literally journal club going on and a craniofacial paper. So like, I gotta listen to this.
How many screens do you have going right now, Justine?
Sorry?
How many screens do you have running right now?
Just 2.
That's not too much to manage.
The world of Zoom. 1 ear for each one.
I heard part of the session though. Those are some good presentations.
Yeah, really nice papers.
Mm-hmm. Mm-hmm.
And really well presented by everyone. Everyone did a great job.
Thanks, April. Hey, so I got a question. So we have this grant writing workshop coming up with the PSF, which is also us, right? So, you know, since I got some of you guys on here, Emma, and let's see who else is around still. Emma, Hirsch, some other trainees here. You guys writing grants? Oh, is it Joselli? You guys writing grants? Anything you guys, any special requests in terms of things that we ought to cover? Well, Allison, we sort of volunteered you. You're on the list of our panelists. I hope it's okay.
Excellent, sure. Yeah, of course.
Great question. Nothing. I mean, I've applied for some institutional grants at my institution that we were lucky enough to get funded. And I vaguely remember applying for a PSF grant like 2 years ago, but we didn't get it. So, I mean, the workshop sounds like a great idea.
Oh yeah, it's our annual workshop, the annual PSF workshop, but it's just, you know, trying to formalize it a little bit more this year with, you know, a little bit of curriculum rather than sort of just like totally like round table. But I just want to make sure we're covering some things that are useful.
Yeah.
Anybody else? Emma, what do you think? You have some grants coming up?
I have no experience writing grants, but you know, it's still kind of a very foreign, intimidating thing. So I mean,
it's like homework,
right?
It's like long homework,
right? And it's the sort of thing I know I probably can't avoid forever in an academic career. So I mean, yeah, just some way to like get more, dumb it down a little bit, dip a toe in the water. If you guys just go over.
Okay, all right, sounds good. Who else is on here? Jason? I don't think I know Jason or Frederick. All right, Kanad, David. Oh, here we go. David, Kristen, what do you guys think? You guys have grants?
I must say I have to echo Emma's experience. I have not been involved in any grant writing, and therefore I think, at least from our perspective, to keep it simple, stupid is probably the best method for getting us up to speed on how to do it. So that would be my 2 cents.
What do you think, Kirsten, or is it Kirsten or Kirsten?
I'm Kirsten. Yeah, you had it right.
Kirsten. Okay. How about you?
I've only applied for 1 research grant, like through our medical school. And so I guess I don't know how different that process was than actual major grants.
That's pretty good. So are you thinking about like, you know, going up with like a, you know, PSF grant or something bigger than that, or?
I think the tough part right now is not knowing where I'm going to be doing residency. And so to start a PSF grant with the current institution that I'm at, that doesn't like follow me potentially could be tough. So it was something I was grappling with.
Oh yeah, I hear you. You know, not necessarily with that, but you know, sort of like I should say the question is more like you got like projects that you sort of think that you might need funding in the future. Is it sort of on the horizon?
Oh, definitely.
Okay, so anything you can think of based on your experience from your medical school grant that might be useful, you know, that you felt like you were unclear about, you would like more direction on?
Probably just common like pitfalls.
Okay, we got that.
So Justine, here's an idea of that from what you said. There seems to be always a disconnect between kind of the size of grants from what you said. I mean, there's the NIH R01 massive grant, but then you also have like the grants for ASMS or different things where like, if you look at the application, they want a 3-page little thing, but oftentimes I'll get my comments back and it's almost like the reviewers wanted an R01 application where there's a disconnect between what they're asking for and what the people looking at it. So it would be, I think that's an interesting topic of discussion is kind of the grantsmanship and how do you format and pitch a grant appropriately, partly because you have to read between the lines what the application says, but you also have to know your audience. And I think that is, particularly when you're starting to learn how to pitch it and how to structure it, there's a disconnect there. And I think that's actually something we could help her kind of speak to.
Well, Allison is like the study section co-chair. So Allison, what you think?
I know, I totally agree. And I think one thing that we need to work on, not only is on writing grants, but also reviewing grants. And I think there's a huge disconnect with the budget available for a grant and what's expected to be done during the grant.
Because that's what I'm kind of, I mean, doing at some point a 30-page grant for like $5,000, just, and that's kind of an exaggeration, but not that much.
No, not that much. Yeah, and part of the trouble is that it gets so competitive for these smaller grants. So then these bigger grants, you know, more detail is great, and then suddenly it's like, wait a second, there's no way they can do this project with this budget. So I think that is something that we need to work on, and that's something I've been frustrated with, and something that I hope we can talk about actually at study section next year with the PSF.
Yeah, it is a lot of work. It's like, it's hard for me personally to sort of put all that together for that small amount of money. Because it's like the same amount of work with shorter page numbers than like an R01. But on the flip side, my very first PSF grant kind of got copied and pasted into a bigger grant. And so, I mean, it's kind of like, it's hard to say. I mean, I'm not 100% sure. Like the ASMS grants, you know, remember my research fellow, like he wrote a few lines and stuff, and that was the end of that. And it was nearly the same amount of money. Okay, not nearly, it's 60% the amount of money.
But still, cost benefit analysis, it's, you know, it's tough.
Yeah, I agree with what Justine's saying is, you know, if your grant gets rejected, just, you could use it, you know, it doesn't stop there. And for the residents and med students, you just got to roll with it and take whatever comments you have and then just go on to the next application. A couple years ago, I applied for, it was like the ASRM, it was like a $5,000 grant, and I even had like prelim data and everything, and got rejected there. But then I added on to it, and then, you know, applied PSF and AAPS and things like that, and kind of rolling that into a K08 grant now. So you just kind of keep building to it and get whatever feedback mentors have for you and whatever comments you get when you submit grants. And that's the best thing about submitting grants, is the comments you get back and learning from what the reviewers are seeing.
Yeah, so this upcoming grant writing workshops, Derek and I are sort of like running the program. And so we just came up with a tentative plan so far to try to kind of, you know, have something for everyone. So some of the stuff is relatively simple, like, you know, 2 panelists talking about top 3 do's and don'ts of grant writing. You know, it's pretty simple, you know, how to kill it on your specific aims page, but then also some things like how to convert a K grant to an R grant, how to stay continuously funded, obviously with like senior level people. So I don't know if that's going to be helpful for some of the faculty too on the call. It's like a 1-hour program, but obviously there's flexibility. So if there's anything that needs to change, and I think we have about like 8 signups or something for a grant, for mainly some junior faculty, some residents and stuff, for mentorship. So some reviews on their ideas.
That'd be great. Yeah, that was actually my question. From my experience with writing IRBs, before we formally submit it, at least at Stony Brook, we can, you know, buzz the ear of someone in the committee just to see if the application looks like it's going in the right direction. I don't know if with PSF it might not be possible, but being able to have someone or someone who's had experience with grant writing or a senior mentor go over the application process and seeing if the draft is in the right direction or what may need to be tweaked and things like that in real time. I don't know if that is too ideal, but.
Right, so that is exactly what is happening, because it's hard to have faculty sort of, you know, at various times being just contacted and like, can you read this grant? Because it takes a minute to read it carefully and do a good job reading it. And so sort of centralizes everybody around, you know, this is approximately what, 6 weeks or so-ish before the PSF deadline. And so if you have anything, even if you had like ideas, like specific aims and you wanted to like run it by just to see what people thought, that would be okay too. Shameless plug for another Zoom meeting. I know.
I was plugging in just a minute before.
Oh, by the way, we have this grant writing workshop. I know you really want another Zoom meeting.
It is really helpful. And if you are preparing a grant, I mean, the more feedback you get, the better it is. And then the other thing I would just say is, somebody said, I think it was maybe, I'm not sure who said it tonight, but someone said, oh, I applied for this, but we didn't get it. But hello, that is part of grant writing. So, like, don't feel bad about it at all. It's like the majority of grant writing is, oh, I didn't get it. So resiliency is a huge part of it. And maybe we can just emphasize that on that Zoom call too. Yeah, so definitely don't be discouraged. Great. Well, I know it's getting late and this Zoom call has been going on and on, but if anyone has anything else they want to ask, please do so. Otherwise, I think we can probably let everyone get to the rest of their evening or get to bed, depending on where you live and what time you go to bed.
Thank you all for sticking around. Where would we find the link for that mentorship meeting that's coming up?
Great question. So the email went out this week with the registration link. So if you email Sarah Boardman,
you can find the link on the PSRC website.
Ah, great.
Yes, perfect. Thank you.
Appreciate it.
Everything's posted there.
Perfect. Then you can register and get the Zoom link. Excellent. Great.
Thank you very much. This is great.
Everybody. All right, guys. Have a good night.
Thank you, everyone.
Bye, guys.
Have a good
Have
night.
a good
Bye.
night.
Night.